Okay, so the good thing about trauma patient assessment is you already have the majority of the assessment done when you learn medical. We're just adding on this trauma component to it. And trauma assessment is always rapid. Right? You have a trauma patient, so you always want to do a rapid assessment. You can't really see this, but this gives you an algorithm sort of to what to go by, but it's off your skill sheet, okay? And this sort of goes down the skill sheet. When you have a trauma patient, you want to sort of evaluate the mechanism of injury, all right? And I think we already talked a lot about the mechanisms, right? The injections, the rollovers, that. So we'll breeze through this. The high index of suspicion. So you size it up in this high index of suspicion. So if the car's all crumbled up and there's a lot of intrusion in it, then that's a high mechanism or high index of suspicion. So ejection. Someone that is ejected from the vehicle, they have about a 75% chance of dying. Most people who are ejected die from that. And when they do these percentages and everything, they're talking about this ejection, the 75%, they're talking about that through an open space. It goes down actually if you are thrown through a windshield or a window or something, okay? So almost always a fatality when you're thrown through the windshield or window. That's why seatbelts are so important. It keeps you inside the vehicle, okay? The death of the same person in the vehicle, so if the driver dies and the passenger is still alive, that creates a high mechanism of injury. An adult faller greater than 20 feet, a rollover. If you look at, what's that called when you have the force that rolls in centrifugal, right? Force, it adds up as you continue to roll. Now you have a rollover from side to side, and you have what's called an endo, which is from end to end that you can roll over. The car will start rolling from front to back instead of side to side, and that increases the mechanism of injury. High-speed collisions, which most of them are. You're talking about the speed limit in most places are 75, right, on the highway, and we go 80 because the standard 5 miles per hour over, right? So almost everybody drives 80 miles per hour. So that's a lot of speed. On a 2-lane road, that produces almost always a fatality. Like a left front to left front just almost produces 1 or 2 fatalities in there. And then intrusion. Do you understand intrusion? I think there's a picture later. But you get the intrusion where the car is intruding into the driver's space or the passenger space. So now you have a driver's seat, but there's a door there now where the driver's seat was, and it pushes you over, right? That would be intrusion. Autopeds, struck on a bicycle, struck on a motorcycle, all sort of the same. Blunt force trauma, like with if you hit up on me while I'm playing golf and I turn around, I'm having a bad day, and I take the 3-iron that I don't ever use and I hit the person in the head with it, that would be blunt force trauma, right? It produces a lot of injury. Rollover penetrating, have some pictures coming up with penetrating injuries as well. There's the common rollover. Some rollovers don't produce any injuries. I can't tell you how many rollovers I've been on that there's no injury because the patient had their seatbelt, the person had their seatbelt on correctly, and they just stayed in the vehicle and rode it out. Cars are designed to protect us. Now they have the side airbags. Some of them do, right? So those side airbags help from the rollovers. Explosions are bad because that concussive force, that force from the energy from the blast, okay, will travel through the body, creating injuries. Definitely not like TV. You rather have seatbelt injuries than not have seatbelt injuries. All right, a lot of them are bruising. You'll see a bruise forming across where the seat belt was on the chest. Anything that damages the steering wheel, where the steering wheel is bent, that's like steel, right? I know that, right? Steel. So when you bend that, you're now the woman of steel, man of steel. You're bending that steering wheel. That is a lot of force that takes place there. To have a bent steering wheel or a broken seat, where the seat is no longer attached to the car, it's broken. That's a lot of injury. And also a prolonged extrication. This takes a lot of time. We'll talk about that 10-minute window that you want on a trauma scene. You need to document a prolonged extrication. There's this picture of intrusion. This is from the rear, but the trunk is now in the back seat. Okay, so that would be, you would estimate that intrusion. Okay, 10 feet for children, 2 or 3 times their height. Bicycle collisions with the motor vehicle. This depends upon how fast the car is going, right? The minimum speed, it's not going to cause a lot of injury, right? Potentially, right? Unrestrained child in the car that's in the collision. Okay, I've been on a wreck, pretty big wreck. The truck wasn't even involved in the wreck. It was on the service road, but the car on the interstate left the interstate through the ditch and went up on the service road and struck the back end of this pickup. The pickup was drivable. They drove the pickup to the hospital, following us with the child that we were doing CPR on. Okay, what had happened was that the car that left the highway at like 70 miles an hour struck the pickup. The child in the back seat of the pickup wasn't restrained, and it threw the child over the top of the driver, and the child struck her head on the A post. Yeah, and killed her. So they would have been calling Geico to get their car fixed. Otherwise, if their child was restrained, they would have drove their car home and called Geico and got their car fixed, instead of following us to hospital while we're doing CPR on the child. So it's very important to make sure that you buckle those kids in. Again, on your skill sheet, spinal mobilization, right? Always considered ALS request, because in trauma you may run into something that you can't handle BLS wise, plus you want your point on your skill sheet, right? So do that. And then always reevaluate, look for a patient who's crashing, who has that critical injury. When we start flipping through this, the AVPU, the sample, the OPQRST, all that is the same. That doesn't change. Okay? Just because they're a trauma patient, that doesn't change. The Glasgow Coma scale, we went over this briefly last year, but it said you won't have to commit it to memory until this year, right? You will have to be very familiar with the Glasgow Coma scale. I think there's a picture, yeah. You need these numbers because you're going on a test type question. You're going to be given a Glasgow Coma, right? Or you may have a scenario where they're telling you different things. The patient has no eye opening, has this, has that, and then you have to figure out the Glasgow Coma score, okay? So be familiar with that. Eye opening, this is sort of the AVPU, right? So spontaneous, their eyes are opening, verbal command, pain, unresponsive, right? Verbal, and then this way you can put a number to it, and then as you reassess, on your reassessment, you reassess your Glasgow Coma. The good news is once you get out, you're not under the written test, weight of the written test, then you can do like I do and you have an app for this or a chart. You just look at your chart and figure out the Glasgow Coma scale. But for now, until you get out of the testing cycle, you need to commit that to memory, and then a motor response, and then no response on each one of them is 1. Okay, so I always say, like, Abraham Lincoln has a Glasgow 3, right? So he doesn't have eyes to open, but no eye opening, no response. So you have the Glasgow Coma scale. Later it gets into the revised trauma scale. You have a pediatric scale. I wouldn't necessarily commit this to memory. I would just be sort of familiar with it. But the adult Glasgow Coma scale, I would commit that more to memory. All right. And these are in your book. The charts are just different ages. This would take a lot of memorization. It would be better just if you had a question over it, just miss the question, then try to memorize that, right? You have enough to memorize already. So do a rapid secondary exam. That's what we're going to be doing in lab this afternoon, is doing a head to toe, where we're looking for injuries. We're looking for these life-threatening injuries. So these inspect, palpate, listen to those lung sounds, okay? Listen for air, use that sense of hearing, like air leaking, like in trauma, you might have a sucking chest wound or something. So that's where you would listen. Smells, different smells, key you in, all right? And then this goes into that acronym that's not up here, but that helps you remember what to look for, like DCAP BTLS. It's just an acronym to describe, to keep in mind during your trauma assessment, your physical exam. This is what you're looking for. You're looking for the DCAP BTLS, which the D, deformity. Just a side note, fractured or dislocated?
Looks like a dislocation.
How would you be able to tell?
Because you can see the shape of the Because you can see the shape of the bone.
Definitively, how will you be able to tell if that's fractured or dislocated? X-ray, right? Yeah, definitely. We don't know. I've seen a lot of those that think, well, that's broken, but it was just dislocated. The doc popped it back into place. Contusions, bruise, right? Man, he made his girlfriend mad. But abrasions, little strawberries like we talked about, that's a pretty good size abrasion. Takes forever for those to heal. No huge bleeding, capillary bleeding. Some sort of puncture wound or penetration, stabbing, gunshot wound. Burns. What degree burn is that?
I think it's second degree.
Why is it second? Anybody remember? It's been a while.
I remember first degree only does like the first layer of skin. Second degree goes through the epidermis and dermis, and then third degree goes all the way through. It goes through the hypodermis.
Well, if we keep it simple, the second degree burn forms the blister.
Okay.
That's how we can tell. Okay, first degree burn's like a sunburn. A second degree burn forms a blister, and a third degree burn is sort of a charring effect, a leathery looking. Okay, so burns, then swelling. They left out the T. Maybe they're not going through that. But the T is for tenderness. Okay, swelling, and then laceration, and then swelling again. I guess I put 2 swellings in there. That's odd. But DCAP BTL is deformities, contusions, abrasions, puncture, burn,
Teacher students,
tenderness,
as many of you know,
laceration,
at 118,
swelling.
something was sent out from the president. It's a test, again, repeat, it's a test alert of the national cell phone. So most of you probably have your cell phone on. You might have seen that. It is only a test. Just a reminder, it's a test. Thank you.
All right. So look for critical findings, especially altered mental status, unresponsive or unequal pupils is a definite sign of a head injury, cerebral spinal fluid from the ears or nose, looks sort of like snot. All right. When we get into spinal cord injuries, we will look at that. It used to, in old school, you would do what's called a halos test. You'd take a 4x4 and dip it in there, and it forms sort of a golden ring around the how you dipped it in there. But now, since we have glucometers for the last 15 years or so, we stick glucometer in there. Then in the presence of glucose, we look for the presence of glucose. No glucose, it's snot. Okay, we can tell. And then you want to read down through and sort of study on these unstable findings of the head and different areas of the body. We won't take the time to go through this right now, but maybe more when we get into the trauma section. However, just sort of look down through there. So it gives you the finding, the possibility, and then the care. And those are important. We will visit this back again when we get into trauma. And then there's more there, more, keep going, right? And then remember we talked about the medical assessment. Not so great really to check the back unless the chief complaint moves you towards the back. But trauma, in a trauma patient, we look head to toe. We want to look for everything. We don't want to miss something, okay? So we'll inspect that back, palpate that back. You notice they're using a log roll technique. You have this guy holding C-spine and then one inspecting the back. And the expectation is there on your trauma patient assessment that you would inspect the back.
Wait, do we vocalize that?
No, you would inspect the back.
Okay.
Okay. So get your blood pressure the same way that you would any patient really. Pulse rate, respiratory rate, skin temperature, condition, check the pupils, check the blood pressure, SpO2. Even in a trauma patient, they may not need oxygen. Okay. Now this has come from the American Heart Association for years, really now. Okay, and they keep putting more data out on it. Old school, not to confuse you, but old school, everybody got oxygen. Every trauma patient got a non-rebreather put on them. Everyone. That was the standard of care. If you have a trauma patient, you put a non-rebreather on them. Old school, not anymore. Okay. Now we evaluate whether they need oxygen, and we evaluate that the same way that we do in a medical patient. Is that are they having increased work of breathing? Are they having dyspnea? They're having trouble breathing? They're using retractions, right? Is their SpO2 less than 94%, right? So if that's the case, then we would apply oxygen. If not, then we wouldn't apply oxygen. The American Heart Association came out with their data saying it's actually detrimental to the trauma patient to put just routine oxygen on them. Okay, so we wouldn't do that. And then here we start talking about cool clammy skin, with patient going into shock, decreasing blood pressure, narrowing pulse pressure, right? Could have a tamponade. These things that are yet to come. Always check the blood glucose level. Remember, any altered mental status, always check the blood glucose level. On the ambulance, you will do that automatically. What they do is if they start the IV, you'll take and check the blood glucose level off the IV catheter. So they'll hand you the IV catheter and say, hey, give me a D-stick. And we'll show you, make sure that you know how to do that. Critical patients every 5 minutes. you have critical or unstable patients every 5 minutes. If you have a stable trauma patient, you can do vital signs every 15 minutes. The sample history is the same. If you can get that information, okay? Gather as much information as you can without delaying transport. And then prepare the patient, rapidly transport them. This is a very important line. Your scene time should be limited to 10 minutes. It used to be called the golden hour, okay? Where that patient, between the time of the incident and definitive care, they want that, which is, for a trauma patient, is probably surgery. Definitive care, 1 hour, okay? So they gave the EMS guys 10 minutes. Anything greater than 10 minutes on a trauma scene is outside your standard of care. It's a violation of standard of care, okay? Unless you have a prolonged extrication or something. That's why you have to document that so well. Extrication, 35 minutes. Otherwise, it's outside the standard of care. You're going to be off that scene in 10 minutes. Our dispatch at one point in time used to send us alerts, like at 10 minutes, and asking us, are we still on scene? Because they knew that we had 10 minutes to get off scene. So and it's still there. You want 10 minutes or less. If you're greater than 10 minutes, make sure that you document that. And then there's a laundry list coming up as far as things that you're going to rapid transport the patient over. This is in your book as well. So keep this in mind as you look. Of course, any trauma patient, you want 10 minutes or less. But these are just things that as you look over them, that you're thinking, yeah, I need to, what we term as load and go. I need to load the patient and go. I tell new paramedics and EMTs, that's why the ambulance has wheels on it. Because most of your patients, you need to load them up in that ambulance and go to the hospital. Not sit on scene so much. Go. My standard was, unless I was trying to intubate the patient or do some advanced airway thing, they'd load the patient and I would expect the EMT or the driver to shut the doors. I can do everything en route to the hospital, right? So that was my sort of deal, medical or trauma. Route, gave all my meds en route. As soon as the stretcher was in the ambulance, I wanted my partner to shut the doors and drive off. With medical or trauma. So here's this GCS again, 13 or less. So you have to sort of that will be, they have sensory, they can't feel their legs, can't move their legs, right? So you might have some sort of neurological spinal cord injury, burns, big medical emergencies like a STEMI. And then triage, we'll get that, we have a whole chapter on it pretty much. Triage is where you have multiple patients. So if I came in here and every one of you guys were injured or something and we had an explosion, or like the chemistry lab had an explosion, then I would come in and start triage. And triage means to sort out. So I'd start sorting you out based on a criteria that we'll learn at a different day, okay? But you would triage the patients out and treat and transport the most critical first. And then you do have to set priorities in management. Those priorities will change as you get more experience, okay? So if you have bilateral open femur fractures, both of the patient's femurs are sticking out of their skin, right? It looks like that should take priority, but what would take priority over that? Bilateral femur fractures, what would take priority over that? Yeah, definitely cardiac arrest, yeah. What else?
Issues breathing.
Airway, right? Airway would take it over. take priority. All right, so unless they're just bleeding out, if they're just bleeding out, let's say they have a massive blood loss through these femurs, what does that fall under?
Circulation.
C, right. So you have to take care of that, ABC, so you have to take care of that. Okay, but if the femurs are just sticking out there and there's no major bleeding, altered mental status, right? Figure out why the patient has an altered mental status. That would take priority, all right, over splinting. So sometimes you do, remember there's only typically 2 of you on an ambulance. All right, so sometimes you have to prioritize your treatment. I've taken patients to the hospital a lot of times with their fractures unsplinted because, I mean, all sorts of things undone assessment, didn't get complete assessment done because airway problems. I couldn't secure the patient's airway for some reason. So that was taking priority over all that other stuff. The airways don't kill them. The femurs, maybe not so. Right? And this is the revised trauma score. I'll have to read it. It's right here. This is in your book, this chart. If you want to look over that. So on a medical patient, they're going to ask you for a Glasgow Coma scale. Okay? What is Glasgow? You tell them. On a trauma patient, you give the Glasgow and you give the revised trauma score. So the revised trauma score takes the Glasgow part of it, but it also counts for the respiratory rate and the systolic blood pressure. So you add those in this chart, so you add those in there. Again, be familiar with it. Putting this to memory, I don't know if that would be well worth your time, but do be familiar with it. The same as the Glasgow Coma scale. And then if you have to do any other type of, a modified exam, that's okay on a trauma patient. That's okay on a medical patient. If you're trying to treat the medical patient, they're having an MI or something, you're trying to treat them for that. It's okay not to worry about the legs, right? Because you're more worried about this person having a heart attack. The legs are probably okay. Unresponsive patients, mostly always bad, okay? The same type thing, rapid assessment, vital signs, hold C-spine, rapid transport, obtain sample. How are you going to obtain a sample history and OPQRST from an unresponsive patient? Bystander, family, right? That's something you have to do. What do you do if you can't get it? I mean, you have an unresponsive patient who was walking across the road from the bar and got struck in the middle of the highway at 3 o'clock in the morning. There's nobody around. You have this unresponsive patient in the middle of the road. Yeah, you just do what you could do, right? You don't have any history. So in your documentation, history unattainable, no bystanders, no information available. It happens a gazillion times. So you just have to adjust. Like you said, just do your best. You don't know. But maybe they'll find that out later. It's always better with the responsive patient because they can tell you, right? Okay. So the same sort of format. And then we go into assessment to make sure that the injuries, the traumatic injuries that they have are not necessarily life-threatening. All patients explain the unresponsiveness. They might have seizures. There might be a DNR. Right? Sample, same thing. Work down through your signs and symptoms. Okay. And each one of these is going to lead you. We haven't got into it yet, but each one. Same thing. A person's alert and oriented is complaint, okay? So your chief complaint is chest pain. You reassess the chest pain, the shortness of breath. You reassess those things. Reassess the vital signs. Reassess the SpO2, right? Make sure the mental status is still ANO times 4, where it began, right? And then you trend these things, okay? You trend the vital signs, you trend the assessment, and then you look at that as a whole and see how your treatment is going. But you always reassess, a good reassessment. Because your reassessment is going to direct your change of, a change may be a change of condition, all right? You may need to intervene. All of a sudden now the patient's not breathing. Does that happen? You have a stable medical patient. You're transporting them to the hospital. It's late at night. You forget to do your reassessment, and now they're not breathing. Yeah, I mean, it's a little creepy, but I've been talking to people. You think I'm boring you? They bored these people to death. But I've been talking to the patient, okay, and this one guy, we were talking about fishing because we were going over Lake Ray Hubbard, and I was doing my paperwork, talking to him, sort of like we're talking, except he's talking back about fishing. I look down to do a little bit more paperwork. I look up, and he's smurfed. He's blue from like the nipple line up. He went into cardiac arrest. He went to PEA actually, and he smurfed. And we had to divert and go to a different hospital. But last thing on his mind was fishing. Then he went into cardiac arrest. I was like, man, I'd stop talking if you want to die because of it. But, you know, many times the patient takes their last breath, okay? So things change quickly, is what I'm trying to get. This guy, the doctor said he just probably had a septal wall blowout, where the hole in the septal wall occurred. That's how most people smurf. You know what I'm talking about, smurfs? Okay. The blue people? Yeah. Okay. So reassess, record your vital signs, make sure that you're looking for trends, negative trends, okay? Check to see if your treatment is doing any good. Abrupt changes in speech patterns. They could all of a sudden have a stroke, right? People's conditions change very rapid. Then adjust your Glasgow Coma scale. Always reassess your ABCs, all right? And just keep looking for different changes. Now your reassessment, you don't necessarily need to do a full head to toe, okay? You just reassess where their complaints are, all right? Record their vital signs, like we're saying, because we don't really use them that much. But since the picture's here, this harness, a lot of times they tuck this in the back of the stretcher, but this is that harness that on some of the tests that they talk about. When you strap the patient, secure the patient to the cot, you secure them with 3 straps, a minimum of 3 straps, and then the shoulder harness. This keeps them, if the ambulance did happen to get into a wreck and they're top heavy, so they roll over quite easy, okay, this would probably keep the patient from sliding out and really injuring themselves. It sort of harnesses in there, because they're strapped in, they can't go anywhere, and so they're just going for the ride. I imagine it would be pretty frightening to them, you know, to be all of a sudden start rolling over like this and not be able to do anything about it. This guy is going to be like a ping pong ball. He's just going to go in all different types of directions. So it's not really feasible a lot of times, but if you can, when you're in the back of the ambulance, buckle in. But most of the times you can't. You're moving around too much during your treatment. But if you can buckle in, do that. I just saw that, and I thought I'd bring it up. Vital signs. Go over the physical exam again, based on the chief complaint. So like if this lady had abdominal pain, if her chief complaint was abdominal pain, then we would reassess that abdominal pain. We'd palpate the abdomen again during reassessment. And then change at what you need, and then obviously document your findings. Right? And we'll go over the head to toe and with Frank over here in just a minute after break, okay? You guys have any questions?
No?